Bismillah ar-Rahman ar-Rahim. Uh, so my name is Dr. Ali Jaratli, and I'm today will continue on our adventure in the lectures for psychiatry. Today we have two lectures, one about mood disorder, which is depression, and the other one about mood disorder 2, which is bipolar disorder. So Bismillah, نبدأ. As you know, major depression comes in episodes. So there will be time where you are fine and then you become depressed. Then depression will sometime get better without medication, but get better also quickly with medications. And then you will have period of normal, and then you go back and be depressed again. So it's episodic. So it comes and goes. And our job is really to treat this patient quickly. The reason why we need to treat the patient with depression quickly is treating depression will shorten the time the patient stay in depression. And as you know, when we are depressed, we lose our ability to function normally. It's very hard to be depressed because your brain will not be functioning well. So we call that unipolar depression. Means you have episode of depression and then normal. We need to differentiate it from the other type of depression, which called bipolar depression. In bipolar depression, we have episode of depression followed by episode of mania or hypomania. So we need to differentiate between the two, the major depression and the bipolar depression, where bipolar depression, there is mania and hypomania and depression. Why? Because if we diagnose it, if we misdiagnose the episode, then we might give the wrong medication to the patient, and that make the patient worse. So anytime we see a patient with depression, we need to make sure that we do good screening if this depression as unipolar depression, that means a depression without any episode of mania, or bipolar depression, which is a depression with mania. So we need to make sure that we know we do the right diagnosis. So depression is very common. 20% of the population have depression. So it's one of the most common illness. In fact, it's now the most common illness in the world is depression, as you can see here. So it is twice in female compared with male. And we mentioned yesterday the reason why female had more vulnerability for depression because they have a lot of responsibility taking care of everybody else and having more sophisticated limbic system. Okay, and the best treatment for depression is always depression and anxiety. We said the best treatment is the combination of cognitive behavioral therapy and medications. So we need to do both CBT, which is cognitive behavioral therapy, or other type of therapy, and antidepressant. And this always red flag means it always come in the exam, these kind of question. The problem with depression is, as we said, there is high rate of suicide. So 5% of the patient with depression might commit suicide. And depression, they look at it now as a not an isolated illness. So most depressed patients have also diabetes and coronary artery disease and vascular disease. So we consider depression as a part of a huge illness, and that illness include depression and diabetes and obesity and coronary artery disease. Type. So in general, the treatment we said is urgent. We need to treat the patient quickly. We don't need to wait to treat the patient. So most depressed patients come after a loss. So Freud, our psychodynamic psychoanalyst founder, said that most patients who have depression, they have loss. Means they have something in childhood, they lose money, they lose some loved one. There is a loss always in depression. But it can come without any reason. So a lot of the patient, they have depression without any reason, but loss make you vulnerable for depression. So when you lose something very important, whether it's a human being, a mother or a father or a son or money or something valuable, it will make you vulnerable for depression, and it change your biology in the brain, it change your brain circuit and make you vulnerable for depression. طيب. Depression make you look negative at life. So most depressed patients, they see life in a dark glasses. They look at things in a different way. And depression is heterogeneous. What we mean by heterogeneous, it has many, many causes, and it can comes in many, many form, in many shape. So that's why we need to be careful in that. What make you vulnerable for depression? Mainly genetic. Genetic is very important in depression. So if you have your mother or father who is depressed, you are more likely to be depressed as your gene will be vulnerable for that depression. The gene is always look at the serotonin transporter. This is what make patient depressed. If you have abnormality in your serotonin gene transporter. This is the one that implicated the most, but there's other genes also. Depression can be a result of health problem like chronic pain, alcohol use, a lot of most patients, like for example, who had lupus or a rheumatoid problem or diabetes, also have depression, as we said. Depression is also, we need to ask for early childhood trauma or abuse usually will change your brain circuit and make you feel depressed. Also, environmental problem, like if you are alone, isolated, if you have environmental stress or anything like that, it will make you vulnerable for depression. So, depressed patient can happen to anybody. Depression can happen to anybody. So you see here, people who are rich, they have 15% depression. People who are poor, they have 11%. So basically, that's mean money will not make you happy, or if you said, because whether you are rich or poor, you are vulnerable for depression. Depression is underdiagnosed and undertreated. Means we are not there is a lot of patients who are not treated for depression. I think there is study show that we only treat properly like 5 or 10% of people who are depressed. So it's very common, and there is a lot of job for us ahead to treat depression. And depression can affect your quality of life, like any other chronic disease. So if you are depressed, you will not be able to accomplish much in your life. You will be working, but you will not have very good creativity and accomplishment. And as we said, depression can يعني, affect your suicidal rate. So most patients with depression have suicide. And here's some statistic, but what I want you to read it on your own. There is a lot of substance use in depression. Most patients will medicate themselves by using drug and alcohol. So there is a lot of those patients who drink alcohol or use drugs. They are really going to the drug dealer across the street rather than coming to see a psychiatrist. A lot of these patients who has depression also have anxiety. We call that mix of anxiety and depression is very common. We call that anxious depression. And you know, one out of five people will suffer from depression in their lifetime. Now, there is a question in the exam always, who is the most vulnerable for suicide in people? And the answer will be unmarried white male over 50. So this is a red flag, means it can't come in the exam. They always bring this question in the exam for a student. Who is the highest rate of suicide are among unmarried white male over age of 50? And that tell you how much important is the social life to prevent depression. So one of the best treatment for depression is to get the patient involved in social activities. Isolation is not good. Now, there is also a caveat. If depression started after age 50, after age 60, then it could be an early stage of dementia. So if you are depressed before age 60 and you still have depression, that's depression. But if your first episode of depression start after 60, then it could be dementia. Diagnosis, I'm sorry here, the spelling is wrong, so we call that diagnosis. We go to DSM-5. DSM-5 said we have to have one of two, either apathy or anhedonia. Apathy and anhedonia, that's mean you don't enjoy anything. So you take you to Disneyland, you give you money, nothing make you happy. So we call that loss of interest or pleasure deafness. Yani there is nothing make you happy. Call that anhedonia and depressed mood. Also, adding to that, there will be weight change. So, patient with depression have either increased appetite or low appetite. Sleep, so people might sleep too much or sleep too little, and they have psychomotor retardation or agitation. So, they are either too tired or too activated. A suicidal thought and cognitive problem also, where a patient with depression cannot think clearly, and if you are depressed you will not be able to pass exam or pass USMLE or SMLE or any exam because your brain executive function is not working well. Also, a lot of patients with depression have feeling of guilt, so they feel guilty. So always I ask my patient, do you feel guilty about anything? Like, for example, not taking care of loved one, not making the right decision at the right time. So there is a lot of guilt feeling. So, and this is another way to look at it. This is a DSM-5 criteria for depression. It's the same like last slide, but I just put it in a different way. So we need to review this carefully, and this is usually come in the exam. However, most patient with depression comes in a physical symptom. We call that psychosomatic. So most patient, they don't admit they have depression, but they come with migraine headache, like chest pain. GI symptom is the most common. We call GI the battleground of our mood. So most of depressed patient have irritable colon or stomach problem, whatever. This is very common in depressed patient because a lot of a lot of society have a stigma about mental illness. So instead of feeling depressed, I will go to the doctor and I say my headache is too bad, I have back pain, I have GI, because I put my depression symptom, I package it in physical symptom because it's much more acceptable to our family and friend. A biological theory of depression will talk about abnormality in three or four neurotransmitters. The first one and the most important one is serotonin. Serotonin is responsible for the basic symptom of depression, like when you feel emotional, when you don't sleep, when you cry a lot, when you feel agitated quickly. This is a serotonin deficiency. So patient with depression, they don't have enough serotonin in their blood. They have lack of serotonin. That's why the most common drugs to treat depression is really SSRIs, which is serotonin reuptake inhibitor, which they increase serotonin in the brain. So most patients with depression have low serotonin, which is responsible for the anxiety and the lack of sleep and the crying. Also, most patients will have low energy. So energy is related to norepinephrine. Norepinephrine, like we said last time, is what give you energy. Too much norepinephrine will make you panic and will make you anxious. But too little also make you depressed. So we need norepinephrine to be in the middle, not too much, not too little. And dopamine is responsible for your motivation. So, for example, when you see a patient who is not motivated, tired, and sleeping, that's mean he had lack of dopamine. When the patient is just purely tired and have no energy, it's mainly norepinephrine. And when the patient is emotional and crying and obsessed with things and anxious, that is serotonin. So we need to know most patients actually have all three deficiency, but most of them will have one or the others, or more in the dopamine and or less in the norepinephrine. So we need to know all of these neurotransmitters. Okay, and so the most important one is really serotonin. And as we know, serotonin is secreted from the midbrain or the brain stem, where there is a nuclei called raphe nuclei. Raphe is the center of the headquarter of the serotonin neuron. So they are located here in the raphe nucleus, and they send their axon throughout the body to the brain and the spinal cord, and that's what is serotonin here. So serotonin is also important for the exam. Serotonin neurons are located in the raphe nucleus in the brainstem. We talked yesterday about norepinephrine. Norepinephrine are located near this. It's called locus coeruleus, where norepinephrine is located, and raphe nucleus is where serotonin are located. So what happens if we don't have enough serotonin? If we don't have enough serotonin, then we become aggressive and impulsive, and we might think of suicide. So patients who commit suicide, if they examine them post-mortem, they will notice that there is low serotonin in their blood and in their brain. So serotonin make us relax and happy. And that's why depression happen after a loss or after a trauma. Why? Because serotonin is the neurotransmitter that make you relax and happy. So if you are not relaxed and not happy, then the body will stop secreting serotonin and you become depressed. That's why we see a lot of depression in patients who had a lot of stress. Because if you are stressed, then the body will tell you that I will not give you serotonin because you don't have time to sleep or be happy or relax because you are busy all the time, and I'll not give you serotonin. An example of that, if I ask my wife, my lovely wife, why you are not making a grape leaf for me? I love a grape leaf. And she will tell me, Dr. Ali, you are never at home. You are always traveling and you're never home. So I will not cook you a grape leaf because are never at home. So this is the same thing. If you are always tense and unhappy and busy and not relaxed, then the body kind of stops secreting serotonin because you don't need it as you are very stressed. So serotonin, and that's what is the correlation between stress and trauma and lack of serotonin and depression. So serotonin comes from an amino acid called tryptophan. Tryptophan is what make you have serotonin. So the father of serotonin is tryptophan, which is an amino acid in bread and in meat, and most food have tryptophan in it. طيب. So basically, any stress in life can make you result in low serotonin, as we said, because your body stop producing serotonin since you don't have time to be happy and relax and sleep. There is many type of depression. There is the first type, which is the most common type, called major depression, where you have only depressive episode and then you get a little bit better and then you have another depressive episode. There is another kind called bipolar depression, which is depression followed by mania or hypomania and then depression. So this is we call bipolar depression. Bipolar depression, there is episode of severe depression where you have psychomotor retardation, and then episode of mania where you have plenty of energy. We're going to talk about mania in the next lecture. There is also one thing called dysthymia. Now they name it persistent depressive symptom, where you have kind of low depressive phase, but they are constant. We said major depression come in episode. Dysthymia is low level of depression, which is chronic and lasts for more than 2 years. So we call that dysthymia or persistent depressive symptom. If you have depression, major depression on the top of dysthymia, we call that double depression. That means you have dysthymia, and then dysthymia become worse, and we call that double depression. So one of the question I ask patient about dysthymia, if the patient tell you I've been depressed for a long time. So we ask him when the last time you felt happy or not depressed, will tell you like in probably 2-3 years. And there is another depression called depression with psychiatric features. That means you have the depressive symptom like this lady here on the left. So she has depression, anhedonia and sad and guilt and all of that lack of social support. Plus, They also, during the severe depression, they have psychosis, like they feel paranoid, they feel hallucinating, they feel psychotic, hear voices, and feel delusional. So we call that major depression with psychotic feature or psychotic depression. So they have different name. We call it psychotic depression or depression with psychotic features. And this is treatment is different. So here we give antidepressant and we give antipsychotic, or also give ECT, electroconvulsive therapy, is the best treatment for psychotic depression. طيب. Also, we have postpartum depression, which depression happen after the birth of the baby in women. So there is two kind of postpartum depression. Postpartum blue, which is very common, and probably 20% of the female have it, where during the after the delivery of the baby, they will have episode of depression for like couple of weeks. It happened in the first year after the delivery of the baby. If the symptom is severe enough to cause that need therapy, we call that postpartum depression. So what is the difference between postpartum depression and postpartum blue? Postpartum blue is mild depression, while postpartum depression is really severe symptom where you really need help and you really need medications and psychotherapy. So it happened in both ways. It's very common. It's usually happen because of lack of support or change in hormone. Because remember, pregnancy kind of prevent depression, because the increase in estrogen and progesterone during pregnancy will put the patient at ease and make you make you relax and happy. But after the delivery of the baby, progesterone and estrogen goes down quickly, sharply. The sharp decline in those is what causes women to feel depressed. There is also another depression called seasonal affective depression, which happened during the time where weather changed, like in the fall. In October is the most common symptom here. It happened in October usually, or late April. Uh, I'm sorry, late September. So it happened because of the lack of sunlight. So most patients will start eating too much. They have low energy, withdrawal. It only happened at that period of time. So we call that winter blue or seasonal affective depression. The best treatment for it is really light therapy. So if there is a question, we use light therapy or bupropion for that. But the best treatment is there is certain light therapy to treat postpartum depression. Uh, what happened to the brain when we are depressed? So the brain in depression, like anxiety, the frontal lobe is what make us happy and think. So in depression, the frontal lobe kind of go offline. If you do a PET scan to the brain of patient who had depression, you see no activity or very few activity in the frontal lobe, the PFC, while you see high activity in the limbic system and the amygdala. The amygdala is, we said yesterday, is become hyperactive in depression and in anxiety. So you see overactivity of the amygdala and underactivity of the frontal lobe. And this is very common in depression and also in anxiety. So this is common in both illness. So in depressed patient, our PFC is kind of offline or weak or hypoactive, while the amygdala is hyperactive. And when the amygdala is hyperactive, it will make you feel negative, it will make you anxious, it will make you fearful, and it will make you think in a negative way about life. For example, one of the best treatment for depression we use is called TMS. TMS is called transmagnetic stimulation. So we put electrolyte on the front of the brain here, and we stimulate the DLPFC here to treat depression. So it's direct stimulation of the DLPFC is like to try to awake the frontal lobe. Or the DLPFC, which is the most important part of the frontal lobe. So most TMS, it's called, is a stimulation of that part of the brain, and it will make you feel less depressed after you take like a 20 session. It's like 20-minute session for 20 or 30 days. And that will stimulate that part of the brain instead of taking medication. So we use it as a treatment for depression. So what happened in depression really, as we said, is in the blue one, you see the healthy one, the frontal lobe is active, mashallah. The patient is creative. The frontal lobe is our creativity and the planning and conscious feeling. When you have good frontal lobe, like most of you, I hope, then you are planning, you are passing exam, you are positive on life, you are looking forward to do things. While in depression, on the here the red one, the frontal lobe is offline, and you are under the mercy of your limbic system, and the limbic system is always make you sometime ruminating. You look negatively in life. You have no motivation. And you feel low energy and you feel depressed. So basically, depression is kind of like the frontal lobe is not working very well and taking care of yourself. So the frontal lobe is our good antidepressant. Then we look at a place in the brain called hypothalamus. Hypothalamus is also very important in depression. When your hypothalamus is depressed, when you are depressed, your hypothalamus is active, meaning that it will increase your ECTH level, making your adrenal glands secreting a lot of cortisol. So most patients with depression have high cortisol. High cortisol or high corticosteroid is synonymous for depression. And when you have high cortisol and high norepinephrine, you don't sleep well, as we said last night, and you become vulnerable for diabetes. So one of the symptoms of high cortisol is sleep disturbance, where patients with depression don't sleep very well because cortisol kind of put you in alert. So you don't have time to sleep or go to deep sleep because of that. And it will make you restless because your cortisol and norepinephrine is high and your heart is pounding and you feel worried a lot. So this is the hypothalamus in depression, and you can see that in depressed patient, the ACTH, which is the part of the HPA axis adrenal gland, secrete more norepinephrine, and that's why you see people under a lot of stress and depressed. They have the moon face, kind of your face become a little bit circle the moon in your face, and that what is sign of stress or depression. So also the hypothalamus is the part of the brain that responsible for your sleep. So it will affect your circadian rhythm. Circadian rhythm, we're going to talk about it in the sleep lectures in detail, inshallah. But for now, you just know that your sleep cycle is disturbed. So people will sleep during the day and have no energy in the morning, and they feel too sleepy in the morning, because in the morning you should be active and you should have a lot of energy. A patient with depression, because disturbed circadian rhythm, their circadian rhythm is disturbed. So the timing of sleep will change from night to day. They have temperature dysregulation and they have high cortisol level, and it might increase your appetite. So some people, when they get depressed, they eat a lot because of that abnormality in the hypothalamus. Remember, hypothalamus is the one that responsible for your appetite. So some people, when they get depressed, they eat a lot. Other people, when they get depressed, they don't eat at all. And that's the irony of depression, because it have the opposite symptom. So patients with depression, they either sleep too much or not sleep at all. They are either eat too much or not eat at all. They either have low energy or high energy. So that's the dilemma of depression. You can have the opposite symptom and you still have depression. The most important part also in the brain is the basal ganglia. And basal ganglia, remember, is the part of the brain responsible for your movement. For example, if you don't have dopamine in the basal ganglia, you will feel tired and sluggish all the time. You just want to sleep. You have no energy to move. Motivation comes from the basal ganglia, where it will make you do things. In depression, the basal ganglia become affected with depression, and the patient will tell you that I stay home, I sit on the couch and never moved out of the couch. Also, there is other part in the brain is very, very important in depression is the hypothalamus. I'm sorry, the hippocampus. Hippocampus is very important in depression because Shalene, a lady named Shalene, did a study, and she found that if you are depressed, your hypothalamus, your hippocampus, I'm sorry, hippocampus, listen to me, I'm confusing you here, but the hippocampus in the breast patient kind of shrink, become smaller. And that's why if you have a depressed patient, you need to treat him quickly because otherwise they lose their hippocampus. And we said hippocampus is the center of our memory. So our memory, all of this information I'm giving you today, you're gonna put it in your hippocampus. This is what I say. I told you in the first time that when I give you lectures, I change your hippocampus, so your hippocampus become different. In the breast patient, your hippocampus is shrinking, and that's why it will become smaller. That's why you really need to treat depression aggressively and quickly, because if you don't, then your hippocampus will shrink. And this see the difference between the healthy hippocampus and the uh, reduced volume hippocampus or atrophy secondary to the depression. Now, we talked yesterday about the DMN, which is the default mode network. Default mode network in healthy person, we said is the person when you are sitting and wondering, when you are driving, when you are taking a shower, your default mode network will become positive and you create things, you think of lectures, you think of positive things, you think of good things you're going to do in the next week or so. In the breast patient, your DMN is always negative. It becomes the opposite. And we said in the first lecture that your DMN can be your best friend or your worst enemy. It will be your best friend when it's positive and always think of future and positive things in life. It can be your enemy if you have a lot of setback in life, then you always think negatively and you always have a dark look at life because DMN will be here very negative. And in psychotherapy, we kind of, and in medication, it kind of decrease the connection of the DMN in the negative connection of the DMN and make you look at life in more positive way. So DMN is what make you look negatively or positively in life. You are either positive and looking for creating chores or mashari or whatever, or you are DMN is depressed and you always look at everything in negative way. And this is like what in DMN in depression is stuck in negativity. I'm a failure, self-criticism, future worry, everything is bad. So the DMN here is the one that make you ruminate like this. A screening tool, what should we do for depression? In primary care, we do what we call PHQ-9, which is kind of screening for depression. So PHQ will give you numbers, and this is a tool we use in hospital to check how depressed you are. So if you score more than 15 or 20, that's mean you are severely depressed. And it's a very good tool, so we use it in primary care and busy physician. Before we diagnose depression, we need to rule out other medical reasons for depression. So if you see a depressed patient, you don't rush into give him antidepressant. You should treat him quickly, but you check his thyroid because thyroid problem might cause depression. You check his infection. He might have some infection, HIV, hepatitis C, lupus. You check for B12, folate, you check for neurological problem. Depression can be early symptom for Parkinson. Depression can be early symptom of, for example, pancreatic cancer. Pancreatic cancer can come first with depression. So always do a good job in screening the patient for physical and uh, other symptom or other reason for depression. Check for alcohol use because most patients they use alcohol to treat their depression, or checking him for like using of benzodiazepine, which kind of also slow the brain down. Let's take a psychodynamic view on depression, and I'll give you a case here to make you understand it. So, in psychodynamic view, Freud said, don't worry about this slide, we'll explain it later. So, Freud said, when you are depressed, you feel angry at yourself. So, Freud called depression anger turned inward. And I know it's difficult to understand, so that's why I'm going to give you a case of that. The case of a Mary, this is one of my patients 10 years ago. Mary is a 25 years old, very beautiful, very attractive, very successful lady, had great DMN, always let her go and explore things and make, connection with people. Came to the clinic with 6 months of history of severe depression. The depression episode happened after she was in love with a guy, and that guy is really good. Not the best one, but he's good. And she was in love with him. However, her family refused that one. They said he is not up to our standard. He is not the same level as our family, and you will not be able to marry him. So she started feeling depressed. Slowly, she started feeling sad, loss of interest, stopped going to work. She started not taking care of herself. She started feeling negative about everything in life. So this is what happened to Mary. Mary was very vivacious, very attractive, very fun-loving, مفعمة بالحيوية. يعني vivacious means in Arabic مفعمة بالحيوية. Uh, then, when her family refused her loved one, she felt hurt. And we said, hurt is when you lose something, you become depressed. So this is the idea about depression: is there is a loss. The loss here in Mary is not having that significant other whom she is in love with. After that, she started being angry, and the first anger she become angry at herself, because we cannot be angry at our parents. So she become angry at herself. What is the symptom of anger at herself? She started being isolated. She stopped going to the gym. She stopped taking care of her hygienes and her hair. And she started not accomplishing much at work. And her anger turned inward. So Mary become from this yellow, beautiful dress to sitting, looking down at the floor and disheveled, not taking care of hygiene. And every time she had another potential for marriage, she will refuse it, and she said, I'm not interested. So this is what happened with Mary. So we call that psychodynamic, according to Freud, is anger turn inward. That means anger become at herself. So she starts being self-destructive. Really self-destructive. يعني not taking care of herself, becoming negative, not taking care of her makeup or hygiene. And so there is a strong association between, this is a theory of Freud, between loss and depression, because she lost that loved one. طيب. So what happened is she had what we call melancholic depression. Melancholic depression is a severe form of depression where you just stand on the edge of the bed. You don't have energy to get out of the bed. You feel so tired. You're so slow. You don't enjoy anything. You have low energy, low motivation. You don't sleep well. You sleep like for 10 hours, but you wake up tired as you sleep. You have difficulty in concentration. You have a pervasive anhedonia, means you cannot enjoy anything. There is nothing make you happy. Not going to the mall, not going to Disneyland, not going to anywhere that make you depressed. And we call that death of the ego. Freud also called it death of the ego. So the ego is who we are. And when Mary in love, look at her when she was in love in college and going to work. Look at Mary now. So Mary now is really have her ego had died. We call it in Arabic, يعني, when you are very, there is one of my friend's wife like this. She was so vivacious and outgoing, and when she got married, she became depressed because of the problem in the relation. So we call it in Arabic انطفت, يعني her light went off. She become, it's exactly changing from Mary in love to Mary in the clinic when she came. She is so sad, so melancholic, not taking care of hygiene. So we call that, Freud call it anger turn inward, or we call it also death of the ego, representing a critical juncture of depression requiring intensive psychotherapy and intensive treatment. So this is what we call psychodynamic of depression. I hope you understanding. So during the interview, Mary was very disheveled, had a flat affect, poor eye contact, which is typical of patient with severe depression. Her mood is very low. She replied, "It's not sad anymore. It's just nothing. I am nothing." Yani it's way beyond feeling sad. It's like beyond I'm not existing. يعني I'm gone. My ego has died. So describe profound dissolution of herself. So it's like she is completely dissolved. She had no interest and no nothing. She accepts terrifying the attachment from her own life. Her ego, she get out of life, as we said. She is out of her life. So Freud called that the death of the ego, dissolution or dissolving herself in reality. The question is, and I talked to her parent at that time, and they were surprised. I mean, why this guy? They look at him, he is really okay, but he is not the best. She can get a lot better man than him. But the parent want the best for their daughter. But they were shocked in why she liked this guy. And this is, if you look at Mary, and Helen Fisher, write this name, Helen Fisher, it's there. She will tell you that when we are in love, there is part of the brain called ventral tegmental area. This is here, down in the brain stem. This is the source of dopamine here, called ventral tegmental area. So if you, and let's see, I'm in love with a lady, and I put a scan, they put me under the scan, and they show me a picture of many ladies. When the lady I love will show up in the picture, this area of the brain will light off, will start lighting. So they say depression is really start in the ventral tegmental area, which we become obsessed about the one we love. So this is what bring dopamine, and we say dopamine is the happy neurotransmitter. This is what make our dopamine high. So, and this area of the brain, if you remember, it's in the midbrain, in the unconscious brain. That's mean we have no control over it because it's the same area where you control your blood pressure, your heart rate, and your breathing. And we don't have control of our heart rate or our breathing because it's deep in the primitive brain, we call it. So that's why Helen Fisher said, you cannot tell someone why you love this one because he doesn't know. It's deep in the unconscious mind. It's deep in the primitive brain. And we say primitive brain, that's mean we don't have a control over it. That's why, if you remember, Khalil Gibran said, don't ask me about one I see in my heart and you see in your eyes, because it's a different way of the looking at things. And that's why Mary is in love with that guy, because that guy is the one who enlightened her ventral tegmental area and make her feel good. And that ventral tegmental area, as we said, is the part of the brain that we don't have control over it. So if you need more details, look at the study, the work of Helen Fisher. Now, Aaron Beck looked at depression in a different way. He looked at it from cognitive theory. Cognitive theory, he said, depressed patient have cognitive distortion. He looked at himself as negative. He looked at the future as negative, and he looked at the world as negative. So he had a triple negative outlook at life. So everything become sad. So he overgeneralized, he personalized, he catastrophically explain everything as a negative, and he look at everything in a negative way. And that's why we treat depression, we say it, with medication and psychotherapy. So in psychotherapy, we try to change this negative outlook at life, and we correct this error in psychotherapy. So here we go. We need to get the patient out of this negativity. So when you look at life, he look at him as bad, the future is helpless, and the world is very hard. This is the way depressed patient look at the triad of things. And he's twisted thinking. So explain, if something good happen, he will make it look bad. If something bad happen, it will make it look very bad. So CBT will break this cycle. CBT will make the patient get out of this negativity, which is located in the default mode network, as we see. The treatment of depression, the most important treatment of depression is really therapy, CBT, and medication. We do also lifestyle, means you need to exercise. So you cannot take just prescription for depression. You need to have CBT or cognitive behavioral therapy. You need to take medication, and you need to do lifestyle change like eating healthy, because fast food can cause you to be depressed because of the additive in it. And you really need to take the medication and do psychotherapy. The medication we use usually, first line will be SSRIs, and I gave the name of the SSRIs, where they increase serotonin in the brain. There is also other medication. I'm not teaching you psychopharmacology, so I will hopefully you will get lectures about it. It is other medication that work on norepinephrine and on dopamine. So treatment also we can use in severe cases called ECT, which electroconvulsive therapy, where we put electrolyte in your brain and we shock it, and that's what we call ECT. It's good for geriatric depression. So patient who is geriatric, there will be best with ECT, or patient with depression with psychiatric symptom. We mentioned that depression with psychosis, the best treatment is really medication, and ECT is the best treatment. And there is also other medication, as we see. Now we'll stop here. We'll take a break for like how many minutes we can take a break here?